I want to call this hearing to order. Good afternoon. Welcome to this hearing on whether vet centers are meeting the mark in addressing our veterans' need, particularly in the areas of mental health. And not only our veterans, but also their families. Vet centers were established in recognition that many Vietnam-era veterans were experiencing readjustment challenges, and those very same veterans were wary of or geographically far from VA medical centers. As a result, the vet center offers veterans the option to receive confidential mental health care services separate from those in the VHA facilities. They are community-based and offer a range of mental health services to eligible service members, vets, their loved ones who experience military-related trauma. They also support a successful transition to military life by offering marriage and family counseling and serving as a resource for other VA benefits and services. Due to the recent efforts by this committee, more veterans are eligible for services at the VA at the vet centers than ever before. That's why it's critically important that the vet center program is delivering high-quality services to the veterans who utilize it. Representatives from the VA, the Office of Inspector General, and the Government Accountability Office are here today to help us better understand improvements that could be made to the program so it meets the needs of all of our veterans. For example, the OIG has indicated that vet center inspection program looking into clinical administrative processes associated with promoting quality care. Patterns have already emerged in the first 9 inspections covering 36 vet centers. I've said it many times before, if there's a problem at one facility, there's likely to be problems at others, and I hope this hearing helps us better understand how the vet center program is addressing the OIG's findings from a system-wide view. To meet increased vet center demand, Congress has taken recent action through the Commander John Scott Hannon Veterans Mental Health Care Improvement Act to the Strong Veterans Act to expand our veteran centers workforce. Given VA's announcement on Friday about meeting its staffing goals, which is good news, I do want to hear from Mr. Fisher about whether this policy shift affects VA center hiring. In addition, other initiatives, such as a pilot program to provide child care for those seeking face-to-face counseling at vet centers, and essentially updates to existing program to reduce transportation costs for veterans accessing in-person care, have been too slow to get off the ground. These programs would help encourage veterans to utilize the important mental health services VA centers offer and need to be a focus of the department and the vet center program. On a recent visit to Missoula Vet Center, my staff was made aware that the Montana Department of Veterans Affairs and the University of Montana both use the vet center to connect with veterans and to operate a veterans legal clinic, which help veterans with discharge upgrades, claims, appeals, wills, and civil legal issues. This is a great example of how VA can partner with local stakeholders to expand services at the vet center and get more veterans coming through their doors. This is especially important in rural areas where vet centers are critical mental health access points for our veterans. So I'm looking forward to our witnesses share with us what's still lacking in the vet center program and how we can work with the VA to make it better. With that, I turn it over to Senator Cassidy for his remarks.
Thank you, Chair Tester, and thanks to our witnesses for being here to discuss vet centers. Veterans' mental health and suicide prevention should be all of our top priority. In addition to vet centers, access to comprehensive mental health care and upstream crisis prevention are important factors in the holistic system of services available to veterans. I was pleased to see the VA recently announced that it will award another $50 million to community organizations to help prevent veteran suicide under the Staff Sergeant Parker Gordon Fox Grant Program, part of the Commander John Scott Hannon Veterans Mental Health Care Improvement Act. You know, you'll sometimes meet the spouse of a vet, and he or she will say, typically a she, I don't know where to go. I know there's a problem, but I'm not sure what to do. Well, the vet centers are obviously a place, that's where you can go. And it brings the fact that if there's a gap between the veteran and the services and their families and the mental health and the readjustment and you name it, that's what the vet center is there to do. In the past year, nearly 250,000 veterans, service members, and their families were able to receive counseling at one of these 300 vet centers. Veterans like them. Vet centers score high on the trust and satisfaction surveys, and vet centers continually succeed in building access to social and psychological services in rural areas that are more difficult for a veteran to find services otherwise. According to the written testimony from the GAO and the Office of Inspector General, there are challenges, though, at the Vet Center. Among these are outreach, staffing, recruitment. I'm also interested in learning how the vet centers interact with the rest of the VHA, where I have a higher level of concern about the effectiveness of the VA supporting veterans' mental health needs. I'm going to soon introduce, it's really hard even on an oversight committee to kind of know these questions. Thank you again for being here. But I'm going to introduce legislation soon called VetPAC, patterned after MedPAC and MACPAC. And VetPAC, we hope, will allow not just this oversight committee, but others to understand these interactions, these workings, in a way that will help Congress better address issues like mental health and suicide prevention. This will help us work with individuals like our witnesses in front of us today to address these important priorities. Veterans in Louisiana and across the country, along with their family members and caregivers, rely, depend, expect high-quality care to be provided by the VA and vet centers. I'm committed to working with the department on finding solutions that help the facilities and the facility staff handle sudden influxes of vets and their family members while making sure that all veterans nationwide receive the care they deserve. With that, I look forward to today's testimony, and I yield.
Thank you, Doctor. Thank you, Dr. Cassidy. I appreciate you being here. Appreciate you filling in for Senator Moran this afternoon. I'd like to invite our witnesses to the afternoon's hearing. First up is going to be Michael Fisher, who is Chief Officer of the Readjustment Counseling Service at the Department of Veterans Affairs. Thank you for being here, Michael. Next, we have Dr. Julie Kroviak, who is the Principal Deputy Assistant Inspector General at the Office of Healthcare Inspections for the VA Office of Inspector General. Thank you for being here, Doctor. And finally, we've got Sharon Silas, Director of Healthcare Team at the Government Accountability Office, and thank you for being here, Sharon. You each have 5 minutes. I would ask you to try to keep it that 5 minutes, knowing that your entire written proposal here will be put in the minutes, and we'll start with you. We'll go in the same order that I introduced you. So, Michael, you're up.
Thank you, and good afternoon, Chairman Tester, Senator Cassidy, and members of the committee. I appreciate the opportunity to join you today to discuss the services available at Readjustment Counseling Services, or RCS, vet centers. Vet centers are a central component of the VHA Comprehensive Service Delivery System, serving a distinct role in facilitating easy access to readjustment counseling to eligible veterans, service members, and their families. They also help overcome barriers to other resources within VA and local communities. These centers offer non-medical counseling to individuals who have served in combat operations, areas of hostility, stateside deployments, or have endured other military service-related trauma. They also cater to those receiving VA educational benefits. The culture and environment of vet centers, along with the military and trauma-informed training and experience of our staff, creates a supportive community that is non-stigmatizing, builds trust, and effectively addresses the needs of our clients. Vet centers are legally separate from VA's general health care facilities and adhere to strict confidentiality practices. Although they operate independently from other places in VHA, there is a bidirectional referral and care coordination system in place to ensure seamless connectivity. The vet center model has significant impact on clients' well-being, and according to over 72,000 customer feedback responses, more than 93% of clients trust vet centers to improve the quality of their life, and over 95% of both new and established clients reported an ability to schedule appointments within a reasonable time. Clients share heartfelt testimonies emphasizing the compassionate care they receive and positive impact on their lives. One example is an OAF veteran who walked into a California vet center in crisis in 2019. This former paratrooper was not sleeping or getting along with his family. He barely found motivation to get out of bed and was experiencing suicide ideation. One counselor, or our counselor, who is also a veteran, met with him on the spot and handled the crisis. Further counseling sessions led to identifying personal goals to address anger, guilt, shame, and intrusive memories. Our team supported with consistent individual and marriage counseling, and he was also able to create a renewed sense of camaraderie through connecting with other veterans in a trauma writing group. As a veteran community, they processed their experiences and began to heal. Following this journey, he has a better relationship with his spouse, a new outlook as a father, earned his PhD in history, where he now works as a professor and advocates for others to seek support at vet centers. Recently enacted legislation expanded services to new cohorts and strengthened our workforce. The Strong Veterans Act of 2022 expanded vet center eligibility to veterans and service members utilizing qualified education benefits and to families of veterans and service members who lost a loved one to suicide. To date, approximately 250 student beneficiaries and 180 family members have benefited from these services. Further, RCS has hired an additional 50 counselors, 48 of whom are on board. Other legislation established the Vet Center Scholarship Program for individuals pursuing advanced mental health-related degrees who will then work at a vet center. VA has awarded 46 scholarships with priority given to veterans, and more awards are anticipated as the application process continues. Finally, RCS is partnering with other VA offices to establish new pilot programs that will benefit and improve access to individuals we serve, to include a pilot to reimburse travel costs for those experiencing financial difficulties in rural and tribal communities, a pilot to provide grants to address food insecurity among veterans and their families, and a pilot to expand the Vet Success on Campus program to additional tribal colleges and universities. Chairman Tester, Senator Cassidy, we would like to express our gratitude for the opportunity to discuss these crucial issues. We value our ongoing partnership and as we collectively fulfill our responsibility to serve the nation's veterans, service members, and their families. Thank you, and I look forward to your questions.
Michael, thank you for your testimony, and there will be questions, I guarantee it. Dr. Kroviak.
Chairman Tester, Senator Cassidy, Senator Tupperville, thank you for the opportunity to discuss the OIG's Vet Center Inspection Program, known as VSIP. These cyclical inspections are designed to help VA vet center counselors provide services that are safe and effective in meeting the needs of their clients. While we recognize the wide array of services provided to veterans, service members, and their families at these centers, we pay particular attention to policies and procedures that identify and support those veterans deemed high risk for suicide. Our oversight work is designed to support and strengthen VHA's important partnership with vet centers in reducing veteran suicide. Independent oversight provides an objective analysis of leaders and frontline staff adherence to VHA policy and their performance in meeting their mission. 3 years into VSIP implementation, we have published reports covering all 5 districts and 9 zones in the vet center system. This week, our teams are in Hawaii, Alaska, Arizona, Oregon, California, and Washington conducting inspections. While we are often encouraged by the dedication of vet center staff during these site visits, we repeatedly find evidence of noncompliance with many required processes, most notably those for assessing and documenting a veteran's suicide risk. Further, our teams are finding repeated failures in internal oversight of staff training and supervision. These deficiencies can have severe consequences. Identifying the deficiencies was an important step, but now with multiple inspections completed, we better understand the factors that contribute to them. The first is a lack of clear and standardized policies necessary to support frontline staff in providing high-quality services to clients. We have repeatedly found instances where vet center staff report confusion, conflicting policy language, or unnecessarily cumbersome processes to conduct basic tasks in support of their clients. Tools such as a SharePoint site that identifies clients as high risk for suicide are neither effectively nor consistently utilized. As many staff report, they were never informed on the purpose. They're perplexed by the inefficiencies and multiple steps to enter basic information, and repeatedly misinformed by the site's inaccurate information. Second, workload and staffing challenges are repeated concerns in most of the vet centers we have visited. During interviews, we frequently meet with leaders in acting positions or leaders assuming multiple roles to compensate for vacancies, which are in part due to the inability to compete with the clinical salaries offered by VA medical centers. This leads to client workload some counselors have described as unsustainable. Finally, a modern and efficient electronic record-keeping system is critical to ensure that required collaboration, coordination, and quality oversight activities not only occur timely, but also meet quality standards. Staff have repeatedly shared their concerns and frustrations with the limited functionality of the current RCS Net system. With the Oracle Health EHRM implementation in a reset phase, when and whether vet centers will have the opportunity to modernize their system remains unclear. Just like in VHA clinical facilities, strong vet center leadership must set the tone for a culture that supports the safety and quality of services for everyone receiving care. A recent report at the South Bend, Indiana Vet Center highlighted leadership failures that jeopardized the care of several clients deemed to be high risk for suicide. The vet center director informally encouraged staff to underrate clients' suicide risks, failed to evaluate staff's completion of safety plans and clinical coordination, and failed to train staff on assessing and managing clients' risks of suicide. Considering that vet centers can be the first door a veteran in crisis opens to engage in care, there is no room for careless and incompetent leadership. The OIG will continue our cyclical reviews of vet centers, building on the lessons learned in earlier reviews and increasing our focus on leaders' oversight of quality operations. We have expanded our review of vet center outreach activities, including mobile vet centers, as engaging those veterans living in underserved and more remote areas is critical to getting needed care to those at risk for suicide. Similar to our recommendation to VHA medical facilities, clear policies and vigilant internal oversight must be structured and standardized, and leadership must hold themselves and their staff accountable to safe, high-quality practices. Chairman Tester and committee members, this concludes my statement, and I'd be happy to take any questions you may have.
Thank you, Doctor, and there will be some. Sharon, you're up.
Chairman Tester, Senator Cassidy, Senator Tuberville, thank you for the opportunity to be here today to discuss GAO's work on VA's vet centers. Vet centers provide a non-institutional access point to receive VA mental health care. They are community-based and offer a range of mental health services in a variety of settings. Vet centers may appeal to certain veteran populations who are reluctant to receive mental health services through a VA medical center and can provide flexibilities that may appeal to certain veterans and military service members and their families. In fiscal year 2023, over 300 vet centers located across the United States provided counseling services to over 104,000 clients. However, successfully meeting the potential of vet centers requires ensuring they are effectively meeting their clients' needs, outreaching to potential populations who could benefit from its services, and addressing barriers to care. My testimony today is based on a report GAO issued in May of 2022, which can provide some insights into VA's vet center efforts. First, in our review, we found that while vet centers have tools to assess whether individuals' veterans' needs were being met throughout the course of treatment, there was not an assessment of whether veterans' needs were being met collectively, that is, by subpopulations that might face different challenges readjusting to civilian life. We found that the RCS had not analyzed information from assessments or surveys to assess what proportion of vet center clients were making progress overall. For example, Vietnam veterans may have different needs than those who served in more recent conflicts, such as Iraq or Afghanistan. Having information across vet centers and assessment of differences across different subpopulations could help RCS better understand and inform vet center efforts and help identify a need for additional services. In our report, we made a recommendation to address this finding, which RCS addressed last spring, and it is now closed as implemented. Second, we found that vet centers lack data that would help better tailor their outreach activities and guidance on how to assess the effectiveness of these efforts. Vet centers are required to develop annual outreach plans tailored to their service area population and engage with community stakeholders to reach veterans. To do this, vet centers use some data to tailor outreach activities such as census data. However, as we discuss in our report, having data that would allow vet centers to better identify certain populations, such as transitioning service members, could help vet centers be more effective in their outreach efforts. We also found vet centers were tracking outreach efforts and collecting data on their contacts with veterans. However, we found that vet centers could benefit from guidance that include metrics and targets for assessing the effectiveness of these outreach activities. Lastly, RCS identified some barriers to vet center care and actions and had taken steps to address those barriers. Specifically, RCS identified barriers to veterans obtaining vet center services. For example, some veterans may lack awareness of vet centers and the services they offer or experience challenges accessing a vet center due to a lack of transportation. RCS had taken steps to address these barriers, such as coordinating with DoD and the National Guard to increase the awareness of vet center services and providing the option to receive mental health services via telehealth. RCS also identified a barrier to vet centers providing services. Specifically, vet centers counselors are required to receive monthly clinical consults with VA Medical Center mental health staff on complex cases. We learned that vet center counselors do not always get the required 4 hours a month because of the availability of VA Medical Center staff to provide those consults. RCS told us that these issues typically get raised at the annual site visits to vet centers, and that if VA medical staff are not available, district mental health staff can fill in. Although RCS had taken steps to address these issues, it had not determined the extent to which their actions had minimized the barriers. Based on the findings for our review, we made 5 recommendations. 4 of them remain open. RCS has taken steps to address these 4 recommendations, including working with VA Office of Information Technology to develop a new software system and piloting a new measurement process to more effectively measure vet centers' outreach efforts. In closing, vet centers can be a powerful tool for VA and play a pivotal role in successfully reaching and delivering quality mental health care to veterans and service members and their families as they adjust to civilian life. RCS and vet centers have taken steps to reach out to potential clients, meet clients' needs, and identify any barriers to access. Fully addressing our recommendations will help RCS and vet centers to increase the effectiveness of these efforts. This concludes my prepared statement. I'm happy to take any questions you have.
Well, thank you for that statement, Sharon, and appreciate all of your statements. I'm gonna start with you, Mr. Fisher. We learned late last week from the VA that it has exceeded its healthcare hiring goals, but will continue to focus hiring on mental health care and concentrate on parts of the country where demand continues to grow. So the question is will this continued hiring focus on mental health care also extend to vet centers?
Thank you for the question, Senator, and yes, it will.
Okay.
There,
We keep going if you want.
Yeah.
That's the answer I wanted to hear. So.
yes, it will.
Okay. So I want to go over to Dr. Kroviak's statement in her document, her testimony. It says, through interviews and surveys of RCS staff, the OIG garnered consistent reports that non-competitive salaries of vet center positions with low grade levels on the general salary pay scale contribute to vacancies. I couldn't find in here where you said that there are a lot of vacancies in our vet centers. In your research, did you find a lot of open positions?
So these are interviews we have with leadership when we go on site where, it is more than anecdotal that they are complaining of staffing shortages and
Gotcha.
increasing workloads.
So, and I, by the way, we all on this committee value the work that both the IG and the GAO does, so I want to thank you for that. They also found that a lot of the positions were in acting positions, which further contributes to not being able to hire people, because unless you're in a full-time position, that becomes a problem. So, for you, Mr. Fisher, Michael, what are you as the head of the vet centers doing? Number one, and then number two, does the secretary know about this? Do the folks up the chain know about this? And are they going to address it moving forward?
Yes, sir. So there's a couple of things that we are doing. The first thing that we are doing is that we've done this past year a full review of all position descriptions and functional statements within our organization to make sure that they are appropriately graded, given our peers within other places in VA medical centers. Those documents are going through the final concurrence process, and we are starting implementation planning to include union notification for rollout. Second thing that we are doing is working to improve our time to fill. Last year was 154 days.
Yeah.
Fiscal year to date, we are at 104 days.
Yeah.
And looking for efficiencies and being able to bring people on faster.
But if in fact our salaries are substandard, you're going to have a hard time getting anybody, much less good people, to go to work for you. Would you agree with that?
I would agree with that.
And hopefully somebody is addressing that if it's not.
We are addressing.
Good. So one of the things that has always appealed to me about vet centers is the same thing that appeals to me about taking somebody that has PTSD and putting them on a river fishing or riding a horse or doing yoga or any of that stuff, is that it's more laid back. It's much less structured, much more welcoming. And to be honest with you, from my perspective, when I've been in them, the stress level is zero. I mean, it's just, things are cool, okay? So number one, do you see that as being a priority for vet centers? And do you encourage that kind of less structured atmosphere where people can let their hair down and talk to other veterans about stuff?
So yes, we do encourage that, and I think that's at the heart of what vet centers are, a non-bureaucratic, no wrong door, come in to begin that journey to set goals.
Okay. And are you seeing overall, and this is a tough question because we've established a lot of vet centers that weren't around 5 years ago, or a lot more than 10 years ago. Are you seeing use by the veterans increasing?
We are seeing increasing usage in certain areas.
What areas are you talking about? Talk to me. What areas are you seeing the increase?
Yeah, we're seeing areas increasing in the south.
Oh, okay.
We're
Oh,
seeing
you're talking about regions. I was thinking
Regions,
about health
excuse me.
issues.
Yep.
Okay. Okay. And then the last question is what kind of use are you seeing from the physically disabled veterans groups?
That is data that we don't have.
Okay.
And that's something that we can take back for the
Okay.
record and be able to answer that more
That'd be
effectively.
good. I'm just curious.
Yeah.
You know, Dr. Cassidy.
Thank you. Obviously, as we all know, there's been an issue at the VA in which a person at suicide risk was counseled by their supervisor to, frankly, lie about the incident. And so it comes to mind, Dr. Groviak, because in your testimony, won't get it quite right, but you said someone was encouraged to understate the risk for suicide, and then you speak of perilous and incompetent leadership remaining in place.
So it was actually the vet center director at the time that was encouraging staff to underrate the client's suicide risk.
Did that vet center supervisor stay in place?
No,
They're gone.
correct.
That's a good thing.
Yes.
Great. Next, you had mentioned the problems with the EHR. How well is somebody who is at risk for suicide integrated into the VA health system, in the sense that, do they get, don't stop, don't, boom, go. You're going to the ER right now, you're going to be in the ER and you're going to be evaluated and they're going to check you out. How well is that integration between those two entities?
So there's no integration between the
Now, we're both
record-keeping
docs.
systems.
The integration may not be formal, but the integration may be, hey, Sam, I got you to take this patient right now.
Correct. So there are requirements for coordination based on an assessment done within the vet center, and much of our work is showing there are inconsistencies or underperformance in meeting the requirements to ensure that veterans who are rated as intermediate or high risk are getting the type of coordination with the clinical or medical side of VHA that they need.
Okay. How pervasive? Do you have a sense of how pervasive that is?
It is quite pervasive. We've published 9 reports. We have been to 36 vet centers, and it is a repeated finding.
Mr. Fisher, how would you respond to that? If this has been going on for some time, it's not brand new, it's pervasive, but not being fixed apparently.
Mm-hmm. Last year, we recognized that this was an enterprise challenge, and we went in and did some process improvements at the national level to ensure that those individuals who come into a vet center are getting those risk assessments and documenting those risk assessments in that first session. Now, if the outcome of those risk assessments, it's determined that they need a higher level of care, our staff are making those connections.
Now, I'm hearing, though, they're not making the connections. I gather on paper they're supposed to, but Dr. Kroviak and the IG has looked at it and said they're not making them. Do you dispute those findings?
What my concern is that I don't know if we are documenting those results correctly.
Dr. Kroviak?
So that may very well be true. The ability to document and timestamp application of these processes is quite limited in RCSNet. But we've also noticed that there are issues with even ensuring that staff are properly trained to conduct the assessments and screenings that they need to be as well. So it is a training and oversight problem as well.
And again, the training issue is pervasive as well.
Correct.
Mr. Fisher, I mean, we're talking suicide. You see what I'm saying? Do you have, is there a stepwise plan that you could send the two of us and we could look at it and we say, oh, this is reasonable. They're addressing it. And we could actually go someplace and see it being implemented and we say, it's actually being implemented. Because I'm hearing from Dr. Kroviak that that's not the case. She didn't say it precisely, but implicit in what she's saying is that it's not happening.
Yes, sir, there is a plan in place, and in locations that that finding happens, that district office creates an action plan to improve those concerns, and we can provide that.
Okay, and Dr. Kroviak, I don't want to keep on putting you on the spot, but I've learned, I practiced medicine for a long time, in institutions that sometimes were not good, even though they had motivated people. An action plan does not necessarily create results. Have you seen the institutions in which these action plans have been implemented, and have you seen whether or not they have been actually effective?
So we don't close the recommendations until we actually review the action plan and accept the action plan as reasonable and accept data that suggests not only is it working, but it's a sustainable improvement place. So for those recommendations that have been closed, you can be assured that we went through that rigorous process before we closed them.
Implicitly, though, that if they are still open, it means that you've not yet seen that.
Correct.
That's important, Mr. Fisher. I yield.
Thank you.
Thanks, Mr. Chairman. I want to ask about a topic that, or an issue that may seem kind of elementary. Why are the vet centers operated separately from the VA healthcare system?
That goes back to our founding in 1979 as being a safe place for the Vietnam combat veteran to come in and to begin to access services. Now, when that individual or those individuals were comfortable, our focus is to create care coordination, referral to other benefits and resources. So our partnership with our local medical centers is about bidirectional referral and care coordination.
But why should the records be completely separate? Why isn't there some integration or joint record keeping?
That goes back to another founding principle of making sure that the veteran or service member is in the driver's seat of their care and they make decisions about who they want their care team to be. Now, if the veteran or service member says, I want my medical center care team to be a part of that, then we begin those conversations, we release records, and we also release information if they're to avert crisis.
Is that something the Inspector General has an opinion on?
So we very much respect the origins of the Vet Center program, and it really was founded on the spirit of a separation between VA and, unfortunately, a lot of mistrust on the part of veterans back during the time when it was founded. So we don't take issue with the fact that there's a separate record. What we take issue with is, especially focusing on reducing veteran suicide, is when that required coordination doesn't take place, regardless of the records communicating with each other.
Well, it seems to me that more than suicide ought to be involved, healthcare generally ought to be integrated. You know, the whole principle, I understand the mistrust at the time of Vietnam.
Sure.
But the VA health care system has come a long way since then, or it should come a long way. And rather than kind of accepting the mistrust as a given, shouldn't we overcome it because the VA healthcare system has the psychiatric and the counseling and other services that are necessary?
Certainly. I just want to be careful to say that these are not clinical or medical services provided in vet centers, so the distinction should be made that it's not that a lack of clinical information is separated by the record separation, but I appreciate what you're saying with how the ease of connecting the two could be appropriate and important for many veterans.
Let me ask you, we have an investigation going in the Permanent Subcommittee on Investigation, which is a part of the Homeland Security Committee. Permanent Subcommittee on Investigation is looking into a program called Operation Fouled Anchor, which was an investigation itself within the Coast Guard of sexual assault. Operation Fouled Anchor was covered up. Sexual assaults, many of them, were never properly investigated or pursued, and many of those survivors left the academy, Coast Guard Academy. Are they able to access services through the vet centers and through your program?
Yes, individuals who experience a military sexual trauma while serving can come into vet centers and also enjoy that confidentiality because they might not yet be ready to have those conversations. One other thing, Senator, if I can bring back up to our separate record system, not every individual that comes into a vet center is eligible for the larger VHA healthcare or ready to make that step. And I think about law enforcement or other individuals who don't have that comfort level yet. Our focus through the informed consent process to help them get there and then make, allow them to make decisions.
But let me just ask about someone who is a survivor or victim of sexual assault while going to one of our academies, whether it's West Point or Naval Academy or a Coast Guard or in training somewhere. Mm-hmm. They haven't been in combat. They haven't actually maybe been formally commissioned. They leave while they're still there. They haven't graduated. Can they get care for the sexual assault that they've suffered and the trauma?
My understanding is that that individual at that point is a member of the military, which would then be eligible for those kind of services at vet centers. But I would like to take that back and just make sure I'm giving you accurate information.
I appreciate that. Thanks, Mr. Chairman.
Thank you, Mr. Chairman. Thanks for what you guys do. What a tough job with all the vets we have and all the wars we've had and look like we're going to have. Ms. Alice, we're not going to leave you out here. I'm going to ask you my first question. The GAO report referenced in your testimony describes many issues related to the lack of effective promotion of vet centers, specifically ensuring vet centers have data on eligible individuals and their service areas to whom they could reach out. Your report points out that vet centers may be able to obtain some data on veterans in their service area, but it is not tailored enough for vet centers to conduct effective overreach or outreach. What progress has the GAO identified, this situation?
Thank you for that question.
I didn't want you to go to sleep.
So what we found was that vet centers were primarily using census data to try to tailor their outreach efforts. And the census data really only goes down to county level, and it doesn't have some of the specific information that would help them be able to target specific veteran populations. And so we made a recommendation for RCS to have some more robust data for the vet centers to tap into. And so RCS is now developing a software solution for vet centers, which would provide vet centers with access to a VA DoD software or a data system that has information on transitioning service members. And it also goes down to the zip code level, so it gets more granular. And then it has more of the demographic information that will help them identify, better identify veterans to outreach to.
So is that software, is it active as we speak? Is it working?
My understanding is still developing. I'm going to defer to Mr. Fisher.
You are correct. We are still developing, and we will be rolling out that this fiscal year after we go through union notification. And that will give us access to transitioning service members so we can reach out to them. We also have a projection model that allows us to go and get understanding of the counseling needs in local communities, given our unique eligibility, which can also help our outreach staff to go and determine where to do targeted outreach.
Yeah. It's about people, right? It's about having good people, especially doing your job. Mr. Fisher, what happens when an individual comes to a vet center seeking counseling, but it is evident to the counselor that the individual is in crisis, perhaps on the verge of hurting themselves or someone else? What happens next?
It is all about getting that individual to the level of care that they need.
Immediately?
Immediately. That could be to our VA medical center peers. It could also be through the local community healthcare systems, 911.
Is there any follow-up from the processing center following that individual to the VA?
There is follow-up. In fact, we have examples of where staff then accompany that veteran to that higher level of care.
Okay. How do vets and the larger Veterans Health Administration interact with each other when it comes to technology? Do y'all, information, data, do y'all interact pretty well from the processing centers to the VAs?
When it comes to us with our peers at VA medical centers, we have that bi-directional referral where, you know, I think about it, if you walk into a vet center with a broken foot, we've got to get you over to the place to fix that. And that is, our focus is on warm handoffs. Now, I think we have locations and communities that we need to do a better job and work on that relationship, that back and forth.
I had a buddy of mine about 4 years ago. Mental health bad, Navy SEAL. He had seen and done things probably none of us would ever imagine. Had huge problems, but had a tough time getting past the front door at some of our VAs. You know, and again, it's about people. You know, actually, security had to escort him out because when you get to that level, you know, it's pretty tough. You know, so again, it all goes back to people. I guess that's all I've got, Mr. Chairman. Thank you.
Thank you, Chairman Tester, and thank you to Ranking Member Moran for holding this hearing today. Thank you to our witnesses for being here today. You know, vet centers provide a great resource that focus on the readjustment and mental health needs of our veterans and current service members. In Arizona, where roughly 10% of our state's population is currently serving or has previously served as a member of our armed forces, the challenges facing our veterans are varied. Based on concerns heard by my office, vet centers can be hard to access for those residing in Arizona's rural and tribal communities, and deficiencies in the client record system and staffing shortages have contributed to heavy workloads prescribed by RCS policies can make accessing mental health care even more difficult. Enhancing access to mental health care is crucial, especially in a confidential setting, as provided at our vet centers. I understand that RCS and vet centers have implemented one of GAO's recommendations in its May 2022 report and have taken some steps in implementing the other 4 recommendations. I encourage RCS and vet centers to continue this progress, especially working to minimize barriers to vet center care. That'll be the focus of my questions. So my first question is to you, Mr. Fisher. My office has been hearing from Arizona veterans and VA staff regarding concerns about unmanageable counselors' workloads, which leads to burnout, high turnover, and of course impacts the quality of care that veterans are receiving. Is RCS still following the 1.5 visits per hour policy, and how are vet centers managing the demand for mental health services while ensuring the quality of care is not impacted?
Sure. So thank you for the question, Senator. I'd like to address the 1.5. There is a formula that we use for what we consider a fully successful counselor. Really, we're asking our counselors to spend half their time doing counseling, outreach, and then associated travel. The other side of that, what I hear in your question is workload, veterans and service members coming in places where there are demand issues, meaning we have more individuals coming in or the amount of time we're spending in front of veterans is increasing. We look to recruit more staff. We also look to move some of that work through virtual services to other vet centers as a Band-Aid while we bring in more staff where needed. The other side of that is our first line of defense is our first level supervisors, that vet center director, who then takes those incoming needs and manages it within the various counselors, as well as requesting those additional resources.
Does the VHA have plans to improve its recruitment and retention policy for quality counselors, including in rural and tribal areas?
We do have plans and have implemented plans to ensure recruitment and retention, whether that is using special salary rates, the recruitment, retention, relocation incentives, scholarships, loan repayments that we are actively using right now to both hire and retain great staff.
And with which incentive program have you seen the most success when you're onboarding quality vet center employees? And then how are vet centers supporting current staff to reduce attrition rates and help the staff manage the increasing demand for services?
We'll have to take it I would like to respectfully take it for the record on which of those incentives is working the best. And I'm sorry, ma'am, can you repeat your second part of your question?
How are the vet centers currently supporting staff to try and reduce attrition rates and help them manage increased demand for services?
Yeah. Well, we go back to, we have processes in place where vet centers can ask for more resources. We also have the incentives that we've talked about to ensure retention as well as recruitment. And then also, our district offices have had conversations and are created action planning with our vet centers around burnout, ideas of burnout that are not covered in workload and other things. It could very well be staff might be interested in going to certain trainings. So we create those opportunities. For both Mr. Fisher and Dr. Kroviak, the Tucson Vet Center recently shared concerns with my team about their electronic client record system and how it's slowing down the delivery of provider care. The Vet Center staff reported the system is decades out of date and contains redundant steps for documenting patient and family interactions. So could you talk to me about what the VA is doing to ensure that vet centers get more effective and up-to-date IT systems for their clinical staff?
So from an oversight perspective, everything you said is exactly what we're finding across the system. The inefficiencies are real. It is a primitive system. It doesn't support functions that you would assume it should in terms of collaboration, coordination, and oversight. Again, we don't understand where the vet centers fit into the modernization attempt, but they have made attempts to enhance the current program. An example would be a reminder that pops up when a suicide risk assessment is due. So we think there can be, or there is space to consider what enhancements can be made to the current program to ensure safety and certainly reduce some of the burdensome workload through electronic efficiencies.
We have partnered with OIT as well as VHA to begin to review needs, what our needs are for a future record system, and then begin to implement those needs. We can provide updates as we go through that process.
I appreciate that. Thank you, Mr. Chair.
Thank you, Mr. Chairman, and thank you all for being here. Mr. Fisher, this should be just a nit. I wouldn't expect you to know this, but my staff had recently gone out to the VA website and then went into the Vet Center National Directory. And the next level down, you only find 3 sites. I think it's Raleigh, Greensboro, Fayetteville. And then you have to drill down further to find Jacksonville. It sounds like simple. When you hit North Carolina, get all the locations. People, I know, regional areas well, but you may have other people looking for these resources to give it to them quickly. So that's just a software modification request. I'm sure your OIT people can take care of that. I also want to talk about the pilot related to outreach. I think you have a path forward there in terms of from the GAO report. They recommended that you're doing a pilot on and tracking effectiveness of outreach. You know what I'm talking about? You have a path forward. I don't think that it's materialized yet. Can you give me an idea of what how many locations are going to be piloted, what sort of time frame we can expect to be implemented?
Yeah, we do expect to implement that in the coming months. As far as locations, we are going to negotiate with the union, and then we will have a set number of locations for that. But it is really focused on looking at the quality of outreach and specifically how many individuals are coming in from outreach into counseling services.
Yeah, so tell me a little bit more about that. I mean, how are you going to be able to measure it? Tell me a little bit about the pilot to where you're really able to connect specific activities to moving the needle in the right direction or not moving the needle, and therefore you got to look at a different alternative.
If we can respectfully take that for the record so we can give you a full outline of everything that we are doing.
Good.
Also, on your comment about the website, we have recently implemented websites for every vet center that includes up-to-date information on the type of services we provide at those locations. We will also take that other item back to look for some
Thank you.
efficiency.
I just think get the information as quick. If somebody's taking the initiative to find this service, you want to make it as easy as possible to get down to that brick and mortar location that
Agreed.
they can go to. Ms. Krobiak, did I pronounce that right? Tell me a little bit in the research. I guess maybe let's look at it a different way. I got a few specific questions, time allowing, but if we've got Veteran Center directors listening to this hearing right now, what's the main takeaway from your perspective from the Office of OIG that they should take away?
Read every report we publish, even if it's not about your vet center. These are risk assessment tools, and it should be spreading like wildfire across the system as to what they need to look at and what they need to fix, or at least assess whether or not they need to fix it.
Do you know if the department? I think that's a great suggestion. It's only as good as the take rate for the to read it, internalize it, execute it. Do you feel that like the department is doing enough to make sure that that's being communicated in the manner that you've just communicated it here?
Honestly, no. I think we'd be seeing more improvements across the system if that was actually into practice as we would like it to be.
Give me a silver lining, if there is one. In your research, did you identify any particularly good, better, or best practices that should be emulated?
Oh, it's communication. So within a vet center, if they have strong communication with the medical center in their locality, we see much better data coming from those centers and much more effective relationships in support of particularly those high-risk clients that we're worried about.
You would have thought that connection would have just been systematized as standard operating procedure. Are there lapses in exactly
So we
what a
certainly
veteran
see
should-
inconsistencies, lack
Would
of
that mean that they're
clarity.
deviating from standard operating procedure, or we haven't properly communicated SOP at that level?
I think the effective oversight and communication to frontline staff has been inconsistent to understand how important just what I described, connecting with the vet center or connecting with the VA medical centers, knowing the names of the people that you need to reach out to for urgent and non-urgent issues, really making that the community for a veteran.
And Mr. Fisher, again, you're going to give me details on the outreach report.
Yes, sir.
Then, Mr. Chair, we'll conclude at this point. Thank you.
Thank you, Senator Tillis. Senator Hassan.
Well, thanks, Mr. Chair, and to you and Ranking Member Moran for this hearing, and thank you to our witnesses not only for being here today, but for the work that you do. Mr. Fisher, vet centers support the mental health needs of veterans who are transitioning out of the military. One of the most critical elements for a successful transition from the military into civilian life is building ties within the local community. So what are vet centers doing to help newly separated veterans build stronger connections within their surrounding communities, and what more should we be doing? One of the things I hear from veterans and actually from community members is we'd love to be there for our veterans. We don't necessarily know who they are. We don't know what they need.
Sure. So the first thing is going out and creating community partnerships within those communities to welcome home all those who serve.
Right.
And then from there, we decide which partners we're going to partner with based off of the needs of those local service member and veteran populations. We've talked previously about a new outreach application that we will be implementing that will give us access to all transitioning service members. So we view that as an opportunity to be able to reach out to them as they come back into their community and begin those conversations, welcome them to a vet center, have them come and check it out, and then from there use our partnership.
Right, and have those partners kind of ready and able at those moments of the first visit. Okay. So another question for you, because I want to dig more into one of the ways that we can build this sense of community, and that's peer support counseling, right? Mm-hmm. So other VA offices, such as the Women's Veterans Network, have seen success in implementing these types of programs which create peer support groups using trained peer support specialists. How can vet centers maximize opportunities to incorporate peer support models into the services that they offer?
Sure. So our view on peer support is veteran to veteran, which is why we hire a large number of veterans.
Right.
All of our outreach staff are veterans, so they can have that shared experience.
Right.
We will go out to the Office of Mental Health and Suicide Prevention to see if there's other opportunities around true peer supports that we can begin to leverage within vet centers, and we can report back to you on our steps.
Sure. Look, the veteran service organizations around my state have really raised this, and whether it's the Buddy Check program or other kinds of programs, what they're telling us and what veterans tell us is that just knowing who the other veterans are in their communities and having that opportunity to find the right match is really important. Mm-hmm. So I'd love to hear more about that from you. Another question for you, Mr. Fisher. I'm particularly interested in how vet centers are tailoring their resources to meet the needs of women veterans. Women are the fastest growing group of veterans using VA services, tripling in number over the past 2 decades. So what type of specialized training do vet center employees receive on the unique military experiences and post-service needs of women veterans, and how does that training impact the care that these women receive?
Sure. So every new employee that comes into RCS goes through new employee orientation, in which we have a military culture block of instruction,
right,
and also have blocks of instruction around working with women veterans. Every one of our districts also create training that is important to the needs within those local communities. Now, your second part of the question is, are we seeing that working? Our customer feedback scores, specifically our trust scores, for women veterans are in line with the national average. So we're seeing that work is successful.
Okay. Just an aside, what I hear from women veterans in New Hampshire is simply they'd like to know where all the other women veterans are, to talk to them, to have a relationship with them. So again, that talks to the kind of informal peer outreach and peer supports that you all can help build. And then last question for you, Mr. Fisher. The May 2022 GAO report that Ms. Silas mentioned in her testimony included a recommendation to assess how well vet centers are collectively meeting the needs of subgroups of veterans. Can you discuss the VA's implementation of this recommendation? What analyses have you completed, and how has vet center leadership made adjustments to services based on these analyses?
So we use our veteran signals, our V-Signals customer feedback tool, to measure those things, which we rolled out in 2021. At the national level, we have enough data to be able to start looking at gender and other demographics. And what we're finding is that there is no real difference in trust scores. Our trust scores are still high. As we move forward and get more data specific to local vet centers, we can start trending and looking to see any opportunities within those local vet centers. Lastly, we've hired a customer experience officer whose role is to really dive down into where are pockets within the country that we can improve around that experience.
Okay, thank you. Thank you, Mr. Chair.
Thank you, Mr. Chairman. I'm really kind of perplexed by all this. We have in my state 700,000 veterans at least. I've done in the last, since the PACT Act passed in August of 20, which probably started right before that, I've done 40 roundtables in 88 counties, and I have a full-time veteran staff person who does others of them. We go to veterans halls, we go to DAVs or Legions or AMVETS, and 15 veterans sit around the table and talk about all this. We have increasing mental health challenges based on all kinds of issues from Vietnam since. And we have, it seems, if not increasing rates of suicide, certainly far, far too many suicides. So why don't, Mr. Fisher, really all three of you, why don't I hear more about these centers? Why do I not hear more from veterans? Well, Ohio has 88 counties. Each of the counties has a appointed office, veteran service office. Some of them 2 people, some of them 50 people in the big counties. And I'm talking to veterans all the time. We've been on this committee with Chairman Tester for our whole careers. Why am I not hearing more about these centers? You want to start with you, Mr. Fisher, and then Dr. Kroviak, and then Ms. Silas.
Yeah, thank you for the question, Senator. I believe that just shows that we have more work to do to get the word out. Every vet center has outreach-specific staff whose focus is to go out and not only create face-to-face connections with veterans, but create partnerships to get that word out. Lastly, as one of the GAO recommendations, we did roll out a survey to try to get a better understanding of why are individuals not understanding or getting more information about vet centers? We're analyzing the results of that, and then we'll get into action planning from there.
Okay, Dr. Kroviak?
Yeah, and we do look at the outreach activities that are conducted at each vet center site, and they are not meeting the mark, the requirements of the number of activities, and that typically relates to competing priorities, workloads, acting positions, vacancies. They're trying to compensate, so they're not consistently engaging in all the outreach activities that they certainly want to and could be.
Ms. Silas?
I was just simply going to mention the same thing that Mr. Fisher mentioned about surveying veterans that are not already engaging with vet centers and trying to gauge awareness and let other veterans know what the services that are available, especially for some of those veterans that are at high risk for suicide.
So, thank you. My state's 12 million people. We have centers in some big cities, Toledo, Columbus, and then we have centers in a medium-sized city, Canton, and then we have centers in sort of suburban areas of big cities, Kettering near Dayton, Norwood near Cincinnati, Oakwood near Dayton, Parma Heights near Cleveland. Should there be more to serve 12 million, well, serve 700,000 plus veterans? Should there be more of these? Should they be staffed at higher rates? You talked about falling short on outreach. What's the problem? Mr. Fisher.
I think to answer that question, while we have those 7 locations, we also have additional multiple sites of care, which we call community access points, that allow us to get into further communities. We can provide you with the number of community access points that we have in your state, but that allows us to get into those distant communities.
Okay. I have a bill that Daniel Harvey and Adam Lambert, Improving Service Member Transition, Reduce Veteran Service Suicide Act, to better prepare service members for civilian life, by connecting them with a VA social worker or nurse. Clearly, we need to, I assume you would support that, Mr. Fisher, or do you know yet?
Yes, sir.
Okay. Would you then, and I'll stop, give some of my time back, Mr. Chairman, would each of you tell Drew in my office and me what we need to do specifically, chapter and verse, so that people understand this service? Because as I said, I rarely hear about this, and I interact with veterans, perhaps, partly because of the size of my state, perhaps as much as anybody on this committee except Senator Tester. And I just don't hear about this. When I hear about problems, I don't hear about this option enough. So would you give me, each of the 3 of you, give my office a step-by-step playbook, if you will, on, sorry, the metaphor there, playbook on what we should be doing?
I think the first thing is making sure that we are committing to regularly scheduled updates with your staff to let them know what we're working on, where our challenges are, where our successes are within your state.
Okay. The other 2 of you would do that, please.
If I could also add that as much as we would like to see the services expand, if your offices could locally support the recommendations in our report and the improvements needed. So enhancing and expanding the services won't help unless the shortcomings and findings that we have are resolved.
And I would just add, I mean, basically all 3 of the findings that we had in our report, if RCS implements those recommendations, it will help with outreach. It will help make sure that veterans are getting information about the services that are involved. And if they are continuing to do periodic assessments of barriers to care at vet centers, then they will also know where they need to kind of target their efforts to make sure that they're being more effective.
Okay, and of course, I didn't give any time back, Mr. Chairman. Could I have another 30 seconds? Thank you. You could, how many, on the average, at these 7 or any other around the country, how many people on the average work at one of these, the vet center?
Between 6 and 7 individuals.
6 and 7, okay. I mean, it just seems when I'm doing these veterans roundtables, I said I've done 39, 40, 41 of them and doing regularly, and a staff person's doing most of the other 80 of the 88 counties. I generally talk for 2 or 3 minutes at the outset, and then the rest of the time is questions and letting the 15 veterans, or asking 15 veterans for questions. This is something I should announce at the beginning of every one of these, what services are available at the vet centers. And I don't do that because I don't know enough to do that, so I need help on that too.
Yes, sir.
Thanks, John.
Thanks, Senator.
Thank you, Mr. Chairman. First, I want to thank the chairman and the ranking member and the committee staff for facilitating an authorized appeal hearing that we had in Maine last Friday it was fabulous, on long-term care. We had really good witnesses, we had veterans, we had officials from the VA, and it was very illuminating and educational, and indicated, for example, that we have nursing home care and we have home-based care, but we have little, if any, assisted living coverage. There's a gap. And so, and also the workforce problems, as you can imagine, were front and center. So it was an excellent hearing, and thank you very much for facilitating that. We almost got closed down by a snowstorm, but we reminded them that their license, their driver's license said Maine, not Arizona. So we managed to stay open. There you go. First, Mr. Fisher, we, as you may recall, we had a problem with the vet center in Portland. Fire hazard, they had to move, find temporary quarters. Joanne Boyle of District 1, I want to acknowledge, did a lot of work to get us into temporary space. And we're looking, we believe that we'll have a permanent location by May. Do you have any information on that? Is that something that we can count on?
Yeah, we are still on track to do that. I also want to thank your staff for helping us move into that temporary space, which is in the same building that our permanent location is.
Good, excellent. There's a pilot under the Cleveland Dole Act for transportation to vet centers, and there's a part of it. One of them is in Bangor, and we have 68 veterans that are using it, but the implementation of the pilot seems to be stuck in rulemaking. And the rulemaking is what constitutes financial hardship. When do you expect we're going to get the pilot operational? And this is really important for rural veterans. We have the top part of the state of Maine is extremely rural. We've got a lot of veterans up there. It's a long way to the nearest vet center. Talk to me about getting this pilot up and running.
Well, we expect the rulemaking process is averaging now 24 months to be able to get through. What's important to us...
Eisenhower retook Europe in 11 months.
Yes, sir.
Just say it.
Yes, sir. What's important to us is the public comment period. Because this is new, we want to make sure that we're accurately defining what financial hardship is.
And that's the... I understand that you want to have input, but let's get on with it.
Yes, sir.
In the meantime, we've got veterans that can't get to the vet center. How about workforce? The vet centers have limited staff. They're really dedicated people. Are you having the same, are the vet centers having the same workforce issues that practically everybody else is?
We are experiencing those workforce issues, and we're working to reduce those, whether that is how we looking at our time to fill and looking for other ways to bring on staff.
Your time to fill, as I look at the data, is better than VHA's, however. I'll compliment you on that.
Thank you. Thank you.
Maybe that's damning with faint praise. I'm not sure.
I'm sorry, say it again.
Damning with faint praise.
Yeah. I think we still have a lot of work to do to bring on staff faster.
I notice, I've looked down the list of all the things that the vet centers, the services they provide, really good, important services, but we've had testimony here that one of the factors, particularly with regard to veteran suicide, is financial questions. And I wonder of your thoughts of adding financial counseling to this list of services, VA benefits, screening, medical issues, substance abuse. Financial advice and counseling, I think, could be an important adjunct to what the vet center provides.
Thank you for that suggestion. We actually have vet centers that have partnered with that type of community partner to be able to provide those services, but we can look into doing that in a more robust way.
I would urge you to take a serious look at that, and we have had testimony at this committee that this is one of the suicide factors. It strikes me as it fits well within the list of services that you're providing. I just want to thank you for the oversight and the work that you've done. Are you satisfied with the implementation of your recommendations?
We are satisfied with the action plans that are put forward to our recommendations. We are not as satisfied that we are repeatedly finding the same things as we go across different vet centers. So we would like the information in one report to be dispersed broadly across the system so that all the vet centers can use that as a risk assessment tool, even though it's not about their particular facility.
Well, my experience has been that the vet centers in Maine are a high-return, low-cost service. Very cost-effective way of serving the needs, meeting the needs of veterans, and I know our veterans appreciate it, so keep it up. Thank you very much. Thank you for your work. Thank you, Mr. Chairman.
Thank you, Mr. Chairman. Mr. Fisher, I wanted to kind of dig deep on a very specific Alaska issue, and I know my staff's been working with your team on it, but we are in the midst of a very heartbreaking spike in mental health challenges among our military members. Now, these are the active duty members, but you're probably tracking, particularly the U.S. Army has had just the number of suicides in the last, I think it's 4 to 5 years, has been 45, north of 45 in one region. I mean, this is more than, the numbers are like through the roof. I was literally just on the phone with the Secretary of Defense on this. And the challenges that relate, so there's a lot of attention being brought to the active duty force in Alaska, but we are having, again, some challenges on this issue as it relates to our veterans. You know, we're struggling with our workforce with regard to the VA. We have more vets per capita in the state and the country. But one of the things that I wanted to mention is that our vet centers are very busy places. They can provide both case management and mental health services. There's this comparison that I know that's been made at the VA here in DC about caseloads as high as 100 per provider, and our caseloads are about 50 per provider. And so I think the VA is either saying, hey, you don't have a problem relative, or you guys are more inefficient. But the results is that no new providers are getting placed in our vet centers, and we think we actually need them. The case managers have a lot more to manage than other states. For example, our hub and spoke model of healthcare means that coordinating both intrastate and out-of-state is more common than other states. Travel in Alaska, as you know, is very challenging. We're a continental-wide state, almost 3 times as big as Texas. We have less road miles in Connecticut. Seasonal depression rates are higher due to the winters. So even though we might have smaller per capita caseloads, our workers we see are overwhelmed, and the formula at the VA is saying there should be no new placements in Alaska. So what I wanted to do, that we need to get more efficient before we get more workers. So what I wanted to do, I know that's a big wind-up, but I wanted to work with you and your team on how the VA formula can be reevaluated to better reflect some of the realities on the ground. As you guys know, one size doesn't fit all. And would you commit to working with me in my office on these issues? And I know we've been talking to your team about it.
Yeah, we will commit to that. We'll do a deep dive into service provision there to see where our opportunities are.
Good. Let me turn to another. The Cleveland-Dole Act, which I voted for, required the VA to hire 50 full-time employees for vet centers to expand mental health services. The bill required the VA to select 50 different locations with unique geography. Were any added to the vet centers in Alaska, do you know, under that? Or are you guys still implementing that?
None of the positions were identified for Alaska, but we have other opportunities to increase our workforce, and I think that goes back to the deep dive that we'll commit to.
Okay, good. And let me ask one final question. Are we seeing any, so I'm very Alaska focused, but of course we're here in the U.S. Senate, so I care about all veterans. Are we seeing any kind of positive signs on veteran mental health or suicide issues nationally, or are the trends still trending in a direction that is continuing to be alarming? And, you know, it's an issue that, of course, this committee cares a lot about, but what are the trend lines, and is there anything in terms of a silver lining that we're seeing with regard to veteran issues, particularly veteran suicide?
Well, I'm going to speak to Vet Centers specific, and I'm going to go to our customer feedback, our trust scores.
Yeah.
And that is, we find that Vet Centers trust us to improve their quality of life. And that means to me we need to make sure we're providing the right services that meet the needs in those local communities, that keep those veterans and service members engaged in services, and then to be able to feel comfortable enough to voice that if they're having a bad day, to say that out loud.
Okay, good. So, but the national trends, that's kind of a little bit beyond the mission of the vet centers that you're focused on, in terms of what you can tell this committee?
Yes, sir.
Anyone else on the panel? Do you guys have a view on that?
So in terms of oversight, the reason we're so involved in overseeing these vet centers is because of that we
Yeah.
are not making, that VHA is not making the gains that it would like to in reducing veteran suicide and the risk for veteran suicide. I'll add that our oversight teams are actually in Alaska this week, so they will be looking at vet centers in your state this
Look,
week.
when the vet centers are there, I agree with Mr. Fisher, the response, you know, it's been great, right? They're really great facilities, and so I think it's a wonderful program, innovative, and maybe it's too early to tell the impact, but I would hope that we're going to start to see some kind of positive impact, particularly on this issue that all of us really care about, which is veteran suicide and these rates that are heartbreaking, and no one wants to see those rates continue. But you think it's too early to tell, Doctor?
Is your question, is it too early to tell the impact of vet centers
Yes.
on the suicide rate?
Yes.
Well, I can tell you, because we're finding consistent shortcomings in the coordination and the steps needed to ensure a veteran's safety in a vet center when they are deemed high risk, I think until we see those improvements at the local vet centers, it's hard to say what type of impact they're having.
Okay.
But we would be happy to reach out to you when we have our conclusions from the sites we visit in Alaska to
That
give
would be
some
great.
local insight into
Good.
what we're finding.
Great, we appreciate it. All right, thank you, Mr. Chairman, appreciate it.
Thank you, Senator Sullivan. I do want to thank the witnesses here. I think this whole committee looks forward to continuing to work to make sure the vet centers are the best they can be. I would say whether it's a GAO recommendation or an IG recommendation, really should roll up the sleeves and get those closed as quickly as possible. I think the GAO recommendations have been out there since May of last year. That's a long time. And I know it's hard to say because we don't have a lot of urgency in the United States Senate or Congress in general, but you got to do better than us, okay? I'd appreciate that. Making sure that we're meeting the needs of the service members and the veterans and the families is what this committee is about. And I think that's the same charge you have, Michael, and I appreciate your work. And we can always do better. We will keep the record open for a week. Until then, this hearing is adjourned.